Hello, students. My name is Dr. Astha Jain. I'm a consultant pediatrician and neonatologist. Today, we will be discussing on a very important topic in pediatrics, which is drug absorption, metabolism, and excretion in pediatric patients. What are the learning objectives of this lesson? It is to understand how pediatric physiology affects pharmacokinetics. So, as we've spoken earlier, pediatrics are not just little adults. The physiology is completely different. And since physiology is different, what your body does to the drug and the drug does to your body is also completely different from that of adults. Number 2, we will be exploring age-related changes in drug absorption, metabolism, and excretion because it is different from how drug is absorbed and metabolized in adults. And as you know, in pediatrics, there is no tailor-made dosage. You have to apply knowledge to adjust pediatric drug dosing safely. What is pharmacokinetics? The meaning of the word is what your body does to the drug. Okay, so it is divided in 4 phases. The first being absorption, second is distribution, metabolism, and finally excretion. Amongst pediatrics also it is different in that of neonates, infants, and then bigger children. So, as the age group progresses, the absorption, distribution, metabolism, and excretion also mature. We will be looking at that. So, they are age dependent in children, especially neonates and infants. Drug absorption in children. Now, how is drug absorption in children different from adults and why is it different? Okay, so these are 3 key points that you will have to remember. Why do we keep saying that drug absorption in children, especially newborns or infants, is different from adults? Because the gastric pH is much alkaline. Okay, gastric pH is alkaline in neonates, and to become like the gastric pH of an adult, it takes around 6 to 8 months, maybe even 1 year. So the pH is much higher in neonates, which definitely affects the solubility and the bioavailability of a particular drug. Then delayed gastric emptying and immature enzyme activity. The gastric emptying, the hours that it takes for gastric emptying in newborns is around 6 to 8 hours. Okay, and it is delayed. Along with that, the enzyme activity, the liver enzymes, your CYP450, all of that is still immature. So, metabolism, a drug metabolism is also slower. Third being reduced bile salts. Since the bile salts are reduced in newborns, you know they affect the fat solubility of a drug, and hence that is affected. So, overall, how does it cause a practical impact in children? This will cause variable and even often reduced absorption in neonates. Now, drug metabolism in children. Liver enzyme systems, CYP450, they are immature at birth. Okay, but metabolism increases with age. It peaks during early childhood. In neonates, the metabolism is much slower metabolism, and hence longer half-life of drugs. In the older children, they require higher mg per kg due to faster metabolism. So your neonates, you will see that the same drug has much lesser mg per kg. Why? Because the metabolism per se is slower. So if somebody asks you, mention 3 points why neonate dosing is lesser, what will you say? You will say that the liver enzymes systems are immature at birth, metabolism is slower at birth, and that causes longer half-life of the drugs. Also, you will see that the body water content in newborns is much higher. Okay, so that also affects your lipid solubility of the drug. Now, talking about drug excretion. Renal excretion, we all agree, is the major route for most of the drugs. But newborns again have a much reduced glomerular filtration rate. Why do you think the GFR is low? Because they still have immature kidneys. Okay, the tubular secretion is low and also reabsorption is low. What does it cause? There is delayed drug clearance. The drug clearance in newborns is much delayed and hence doses have to be adjusted. Also, I am talking about neonates here, but please understand that there are children who suffer from renal disorders. Suppose there is a child of chronic kidney disease. Will you be giving the same dosages of drug to this child as the child who's completely normal, who has no disease? No. There are renal adjustments to the drugs that are made because a child has a particular disorder. Clinical implications. Now in a neonate, absorption is slower. Please note this down. This is a good table. In a neonate, absorption is slower, metabolism is slower, excretion is slower. From neonate, we move on to infant. Who's an infant? Somebody from 1 year of age is called an infant. So absorption is mostly variable, metabolism is gradual, it increases gradually. You see that up sign, it increases gradually. So both metabolism and excretion, they increase gradually. And in a child, absorption is normal, metabolism is much faster, and excretion is normal. Always consider maturity of organ systems when you're prescribing a drug. How is it relevant to you in your OPD or IPD practice? In the OPD, prescribe safe oral medications with correct frequency and dosing. You should know the weight of the child. You should know how often this drug has to be given during the day, and you should know the exact dosage of the drug that you're giving. The standard textbook that you can refer to, it is also available online as a PDF format, is for pediatrics, I'm saying, is a Harriet Lane textbook. Download that. They have all the drugs. This is for pediatrics, and for newborns there is a standard textbook that we normally use, which is called as NeoFax. NeoFax. This book has the drug dosages, frequency, drug dose adjustments, all of that for newborns. In the IPD, you will be very careful about the hepatic and the renal function before starting IV medications. Whatever medication you are giving, you will have to understand the implications of it. And if you're giving something like aminoglycosides or even vancomycin, you know that you will have to monitor creatinine in this patient, BUN in this patient. If a drug is metabolized hepatically, that is through the liver, then what do you have to check? You will have to check SGPT in such kind of patients. So you should know what medication you are giving, what implication is it going to have on your liver or kidney, and do according tests. Also adjust drug intervals and dose in neonatal ICU. Pediatric renal and hepatic impairment, as we've already spoken, in a child who has acute liver failure, you will not be giving a drug at full dosage which has hepatic clearance. You will have to make adjustments. All of that is also given in your Harriet Lane. Okay, so that presence of mind you should have, that if there is a child who has a kidney disorder, something serious, I'm not talking about a basic UTI, no, but if there is a kidney disorder, then you will have to adjust the dosage as per the renal clearance. Now summarizing, pediatric patients show distinct pharmacokinetic profiles, right? We've already spoken about that. There are immature absorption, metabolism and excretion systems. There is age specific dose and interval adjustments are essential. And every morning, I'm talking about IPD, every morning these dosages are recalculated so that one person hasn't gone wrong. Okay, so especially in the ICU, what we do is that if one person is calculated, one person rechecks it. That important your drug dosages are, because you do not want to be underdosing or overdosing a child. Monitoring is key to avoid toxicity and treatment failure, right? So as we've spoken, monitoring SGPT, monitoring creat, BUN to check for hepatic and renal clearance is very, very important. That is all for this lecture, students. Thank you.